Um, I wanted to kind of talk about IPL. And so I've been doing co-managing patients with David Harden for many years, and we got to a point where it was kind of, I really had a lot of interest in seeing these patients and taking care of these patients, and I started doing them, the IPL treatments myself, over about 2 years ago. And so last year I was up in this symposium, kind of talking about IPL, and I've kind of refined the way that I kind of look at it a little bit. I've learned some more things about how we select patients for IPL. And then even just since last year, there's been a significant amount of interest in IPL as a treatment for ocular surface disease, and because of that, there's a lot of more clinical studies that have looked into how is this thing really effective for our patients. And so I don't have any relevant financial disclosures, and so this is my disclosure slide. But when I think about IPL, of course, this is a condition that you will begin to evaluate without even looking at the patient in the slit lamp. Oftentimes you see these patients and you know that this inflammation that's very evident on their nose and on their cheeks is something that has to at some point factor into your discussion, your assessment, and your treatment of that patient. And so we know, just like all other inflammatory conditions, that if this is left alone, it will progress. And so two very important and key things to remember once you see these telangiectatic, folks with telangiectatic changes on their cheeks and on their nose, is that this is an inflammatory condition that will be very relevant to treating this patient's ocular surface disease, and if we leave it alone, that this is something that is most likely going to progress. It's kind of like, their conversation about Demodex. What should we do about it? And so this is the reason why this is relevant is that now, as we have a lot of clinical studies that have looked into IPL, we know that about 80 to 90% of the patients that have rosacea have Meibomian gland dysfunction. And so this talk is really kind of a Meibomian gland. If we're thinking about inflammation, what have we learned about how that inflammation directly relates to the Meibomian glands? And this is such a strong correlation between these two things that we really have to think about how do we address it? What's the level of kind of how aggressive should we be with these patients, knowing that 80-90% of these patients will have Meibomian gland dysfunction. And so when you see it you don't necessarily have to see it just along the lid margin. If you see it on their cheeks and on their nose, and their eye is relatively quiet, in my experience, the discussion about how this is likely to affect the glands that deliver oil to the surface of the eye, this is a good place to start doing that because of this data that we have now. And so I know that Whitney had a similar series of slides, and so I'm not going to really but what's interesting for me is that our work on inflammation and ocular surface disease from our experts many years ago, it seemed to me, obviously correctly identified inflammation as a key role. But to me, our early work really looked like Meibomian gland dysfunction was a little bit of an afterthought in the DEWS, sort of first stab at it. Inflammation, of course, was very correctly identified as one of the key drivers of ocular surface disease and dry eye. But it seemed like to me there wasn't as much of an emphasis on Meibomian gland dysfunction. But I think since then, our subsequent work in this area has really outlined how critical Meibomian gland dysfunction and Meibomian gland disease in this ocular surface disease. And this study is actually titled "The Vicious Cycle of Dry Eye Disease." And so it's actually a very central component of treating ocular surface disease. And then if we look at all the things that we now have kind of pinned down a little bit more as far as treatments, again, this is all kind of a narrow path to really focusing on anti-inflammatory treatments and directly looking at the Meibomian gland. And so this has really been, my initial sort of approach to using IPL or adding IPL to our treatments for ocular surface disease has really been focused on the telangiectatic blood vessels. And then when we do more and more of this, we know that this is, this is all going to be helping the health of the meibomian glands. And that's really an added incentive to really discuss with these patients in addition to the other anti-inflammatory medications. This is a slide you've all seen before. This is work done by Don Korb that helped us identify we really need about 5 to 6 healthy glands on these patients to, most of these patients to not have significant ocular surface disease symptoms. And so these folks that had about 5 to 6 healthy meibomian glands delivering, picture perfect meibum to the surface of the eye, had speed scores that were very low, and they weren't very symptomatic. So this is why, one of the reasons that I really ask a lot of my folks around me to really make sure we do a speed questionnaire on every one of our patients is that it's such a good marker of where we're headed with their treatment and whether that treatment is on pace and heading in the right direction. So speed questionnaires are really important, and it doesn't have to be a speed questionnaire. It can be any other kind of questionnaire, but some sort of a symptoms questionnaire is really important for guiding the treatment when we see these patients on follow-up. Now, it's important, of course, to try and understand what is the health of that meibum. So the number of glands delivering, or meibomian glands yielding lipid is important, but the quality of that oil is also very important. And so if that meibomian gland is sitting in this telangiectatic inflamed lid chronically, at some point you start to see dysfunction of the meibum itself that's coming out. And so we want all patients to have kind of a nice, healthy, clear oil. And even on this diagram, you see the lid where it says kind of clear liquid oil. Even though we have that oil coming out and it doesn't look like it's very thick and like a toothpaste, that lid to me is not healthy. And so even in our kind of in our clinical studies where we've kind of demonstrated healthy oily glands, for me it's really important to see that we have to treat the environment where that meibomian gland is sitting. And so decreasing those telangiectatic blood vessels is very important because we know that if we don't do that, at some point that oil is going to start to become dysfunctional. So it's important to have glands that are delivering oil, but what is the quality of that oil on the surface of the eye? And so that's why it's important to kind of do some kind of expression and to kind of gauge how sort of what's the quality of the oil that's staying on the surface of the eye. And you can see this is kind of a progression of the atrophic changes along the lid if inflammatory changes are not treated in your treatment plan. And so we know that, again, because of work done previously, knowing that most dry eye patients have an evaporative component. So we've just identified that if a patient walks into your practice and they have telangiectatic changes on their cheeks, they probably have meibomian gland dysfunction. And we know that meibomian gland dysfunction is involved in about 85% of all patients having dry eye. It's a component, it's a part of 85% of patients that have dry eye. And so when we put those two pieces together, of course it makes sense that we're now thinking of meibomian gland dysfunction as Whitney probably said before, and as that Boudin study said, this is the entry point for dry eye. So if there's one thing that I would think I really have to focus on and really preserve when I see all of my dry eye patients, it's the meibomian gland. And so when we zoom out and look at the lid, this is why we have to really treat the lids aggressively so that we can really preserve the meibomian glands. And so in our little workshop yesterday, that's what Steve Maskin was saying. He used the analogy of being the offensive lineman. He described the meibomian gland as his quarterback, and he's got to try to do everything to try to defend it. This is one of those things. Again, when our patients come in and they have untreated blepharitis like this, at some point those meibomian glands are going to start to get affected by that. And there are tons of different examples of why we have chronically inflamed lids. Some of it is kind of squamous blepharitis and things, buildup of biofilm on the tear film, Demodex blepharitis. This is a patient that has alpha-GAN follicular conjunctivitis. So it doesn't necessarily only have to be, kind of a blepharitis patient, but sometimes medications that patients are taking will need to be kind of thinking about what other things can we be doing to improve the health of the lid. This is a patient of mine who is a MRSA patient, and you can kind of appreciate on your right-hand side there, all of those glands are completely obstructed and completely blocked. There's nothing coming out of those glands. And you can see those telangiectatic blood vessels there. This is really one of the best, I think, kind of pictures I've really taken. This one's kind of ingrained in my mind that the telangiectatic blood vessels right around the environment where those glands are sitting are really important for the health of the glands. This is, of course, very common in patients that have had previous lid surgery. And so this patient has had lesion excision and has notching on the lower lid. So we know that the chance of that patient having really healthy, functional 5 to 6 glands that are doing everything perfectly is a lot less than the perfect patient because they've had previous surgery. Some of those glands are just gone. And so you really have to maximize every effort that you can to try to really preserve the ones that they still have, right? And so we see a lot of patients with eyelid inflammation, but it's not just the chronic rosacea or blepharitis patient. Keep in mind these patients that have had previous lid surgery or maybe have different medications that they're using or have really strong allergies, we have to treat those just as aggressively to try to get that inflammation to be quieted down on the tear film. Because one of the things that we really have to defend is making sure that meibum delivery is heading in one direction. When there's prolonged inflammation in the lid, we start to see the reversal of the flow of the meibum, and that is one of the key critical steps in the beginning of the atrophy of the acini, and so we really want to keep that oil delivery to the surface of the eye. So once if this process continues, again, without aggressive enough treatment to halt the inflammation, in some patients, when we pull down on the lid, we actually see the cicatricial or scarring of the gland itself, and we see the abnormal migration of the line of marks. And when you pull down on the lid, you can actually see the central duct of the Meibomian gland. You're not supposed to be seeing that, right? And so the healthy Meibomian gland is that one there right on your left-hand side where you're supposed to just be looking at the orifice or the opening of the gland. When you start to see tortuosity of that gland, it's important for us to elevate we'd be a little bit more aggressive with our treatment plan because that gland is now torqued, and we have to really aggressively address the inflammation because we know the next part of that in an inflamed lid is that we'll have pockets of this complete atrophy or dropout of the glands. Okay, so all of this again is just really pointing to the importance of treating inflammation on the lids and being a very good detective and understanding where's every little reason for that inflammation. And then patients that have this rosacea are only probably going to get worse if we don't address it. And if it's just kind of lingering there and we haven't addressed it aggressively enough, of course, that's going to start to affect the ocular surface. You've all seen these staph hypersensitivity patients that will just have a beat up epithelium and then these sterile marginal infiltrates every so often. And so at some point, the glands atrophy and the cornea is likely to get compromised and the epithelium becomes damaged. And in some cases, in some severe cases, we start to see vision-threatening trouble. This is a patient with a lot of autoimmune problems, but sometimes patients will ask, well, what's the worst thing that can happen? I know I have rosacea. What's the worst thing that can happen? I don't know if some of you guys were here last year, but David Harden had probably the best response I've ever heard on that question. And it ended up being this discussion with the patient that ended up with him dying and her dying. And so it was like the funniest and most appropriate kind of, you sort of, it does happen. It does happen that we start to see vision-threatening problems if we're not addressing these very apparent signs aggressively. So paying really close attention to these patients' lids is important, but we have to follow up with what we're seeing clinically. I really advocate everybody in this room to be very up front with these patients. When you see rosacea, we have to address that with the patient, and we have to have a discussion about what this can potentially lead to if we're not aggressive enough in treating it. And so the skin-eye connection, sometimes patients are just, they can't really articulate why their eyes are bothering them, but making that connection for them is really important. So that's the first step, is to really make sure that we're addressing inflammation. The discussion has to happen when you see these patients that have inflammatory changes on the lids. And so I'm saying all of this to kind of, this is, we know that these patients that have obvious inflammation on the lids need treatment and need a discussion. But what's also interesting to me is that there is non-apparent inflammation or ocular inflammation. So this was a clinical study that looked at confocal microscopy images of the palpebral conjunctiva on patients that were normal, and then the other subgroup of patients that were refractory to Meibomian gland disease. And so you can see there that the image on the right-hand side, there's this kind of pouting, a little bit of sort of signs of Meibomian gland dysfunction. But what's interesting is that these epithelial immune cells are in much higher concentration in the patients that have refractory Meibomian gland disease. And so when they looked at the lids of these patients, this is in vivo confocal microscopy, you could see a higher incidence or higher number of these immune cells. That graph is actually the same graph. I think maybe that's the old version of my talk. But in case you missed it, you could. But it's nearly a 5-fold increase in the group of patients that are refractory to the basic Meibomian gland dysfunction. What's also interesting to me, there's on that left-hand side, you can actually see the glands, the Meibomian glands, and then on the right-hand side, you see more of a dilated Meibomian gland, which is, we all know that when we kind of take a look at the Meibomian glands, we see a dilated gland there. That's one of the signs of Meibomian gland dysfunction. That Meibomian gland is under stress. But these patients didn't have, this was non-apparent ocular surface inflammation. So this is not the patient that has conjunctival injection and significant inflammation in the eye. And when they did further, kind of look into the scans, their features, they also did confocal microscopy of the corneal stroma and found these stromal immune cells as well. And so the higher number of these immune cells is very, very highly correlates with refractory Meibomian gland disease compared to the healthy patient. And these dendritic cells in the corneal stroma were again found to be in higher concentration in these patients. This is nearly a 3-fold increase in these patients that are refractory to Meibomian gland, to treatment. And so, and on this last kind of slide here on that same study really shows that there's a bunch of different features, again, compared with the normals being on your left-hand side and the patients that had non-apparent inflammation that were kind of refractory to the basic treatments. They saw subepithelial fibrosis and some lymphatic changes in their palpebral conjunctiva. And what's really interesting on that bottom right-hand image is that they saw that there is these abnormal blood vessels there. So within the lid margin, we see that these patients that have ocular surface inflammation on the lids, it doesn't necessarily jump out at you. These are patients that had non-apparent ocular surface inflammation. And so that's what's happening underneath, the lids. And so I think about that study frequently because once you see this is probably has been happening at a higher level before you even saw this. This inflammation is happening, on the confocal level. So these patients, and it makes perfect sense with other things that we know about, non-obvious Meibomian gland dysfunction, or sometimes these patients that have really significant symptoms, but they don't really show the epithelium is sort of still intact. So this inflammation has been going on for quite a while if we, before it actually manifests in front of our eyes at the slit lamp. And this is where all of this has been kind of a lead up to the IPL technology that we have today. It specifically really addresses closing off those telangiectatic blood vessels. And so this is as you know, this is not a laser treatment. This is a non-coherent light source. And so that's the other piece that's really important to kind of communicate to the patient. We're not doing a laser treatment, and this is going to directly close off those abnormal blood vessels that can negatively affect the health of these glands, which are central to most cases of dry eye. And so that really kind of simplifies it, and it's very easy to back that up with all the data that we have now. And so IPL, as you know, it targets the chromophores of the skin, the oxyhemoglobin, and the melanin. And so we want to try to the patient base that we recommend to have this treatment should have kind of a lighter skin so that we don't have most of the energy absorbed by the pigment cells. And so that's why this sort of range is what is targeted. The area where we have a higher absorption of the oxyhemoglobin is the range that's very useful for closing off these 60 micron telangiectatic blood vessels. So it's a very targeted treatment to clearing away inflammation that is very important for treating all patients with dry eye. And so the technology that we have at our hands right now with IPL is very sort of improved, much improved compared to our first iterations where we would deliver a pulse of IPL, and there's kind of a lot of energy or higher energy at the beginning of the pulse, and then it kind of fades off. Now we have this technology at our hands that has kind of a top hat delivery where we know that the amount of energy is at the same rate for each pulse every time it's delivered to the eye. And so so we sort of treat, this is kind of a diagram showing where we treat from tragus to tragus. I usually try to avoid going all the way out to the tragus so I don't really get too much of the hair of the patients, but I move back and forth along the lid margin and right along the infraorbital rim as close as I can get to the lashes. And I use a lot of ultrasound gel, a liberal amount of ultrasound gel to help to sort of evenly distribute the energy to the lids, this is a treatment that the patient's not knocked out for this. So you talk to the patient during the procedure, and they really help you help guide your treatment. If they're really uncomfortable, sometimes I'll cut it back a little bit, but I go back and forth along the lid margin, and in most patients I can go about 3 passes on each side. At the very end, if I feel like they're tolerating it very well, I'll ask them, I'll say, I would like to do another pass if you're up for it, and most of the time they'll say yes. And in fact, what I've been doing more that I sort of haven't been doing initially is using the kind of the numbing protocol for Meibomian gland probing has been very helpful for tolerating IPL. And so I use that lidocaine gel on these patients and leave it there for about 20 minutes, and then come in and do IPL. And I found that they're much more comfortable with the treatment. So initially when I started doing it, there's sort of some flinching and discomfort, and you can see that, but it's definitely much more tolerable after doing that. So I typically do 3 to 4 passes, but what's interesting to me is the clinical studies that we have now that we didn't even have last year really are talking more about what else should we be doing, not just IPL, but how can we combine this with other things that we know are effective. And so most of us now are doing IPL with some other kind of a treatment to the Meibomian glands. As I've kind of laid out in the beginning part of this talk, how those things are really sort of go hand in hand. Eyelid inflammation, always sort of be thinking about what's happening to that Meibomian gland, which is really critical. I mentioned earlier that we want to offer this treatment for patients that are kind of fair skin, so we don't have too much of the energy being absorbed by the the melanin cells, and I typically will treat, this is the Fitzpatrick skin scale. I'll treat patients through, most of the patients that I treat are 1 to 3. I have treated patients that are level 4, but I think it's a contraindication to treat patients that are at level 5. Again, for that same reason that we want basically those telangiectatic blood vessels and nothing else. And so we want to, the basic kind of patient considerations, you really ask patients to avoid using creams. And once you see the eyelid tattoos, you really have to be careful not to go too close to the lid margin. So I'll usually try to get as close as I can, especially after I do one pass, I'll go out here, and then I usually actually take the shield and move it off to the side and use my finger to keep the lid closed. And then I go all the way as close as I can to the lid margin here. And so not everybody does it that way. Most people will keep a shield on the whole time. But again, I've been doing it over 20 years, and I haven't had any problems doing it that way. There are some of our colleagues that will use a corneal shield and then treat right on the upper lid. And I just have an IPL machine that doesn't really accommodate that now, but I think that's a very smart thing to do. And so these are other things, some things in the literature about contact lens tattooing with IPL and iris photoablation. These are things where patients really, a colored contact lens needs to come out before you do IPL, and we shouldn't do IPL on the upper lid without some sort of a corneal shield. And so other considerations, we want to exclude patients that are going to be out in the sun that day or expecting to be out in the sun. These are all common sense things. Again, I've been treating patients for a couple of years, and I find that I haven't had any trouble with patients that have had a history of HSV, but I do have them kind of use, kind of go through a little bit higher concentration of Valtrex around the treatment. So I mentioned before, a lot of the studies are kind of looking at IPL plus Meibomian gland expression. And this was a clinical study that looked at Meibomian gland expression versus IPL and Meibomian gland expression. I don't know why they decided to use MGX for Meibomian gland expression. It should be MGE, but anyway. So they treated these patients. They had 8 treatments, and there were about 3-week intervals. And they looked at lipid layer thickness, non-invasive tear breakup, lid margin abnormalities, and then the Meibom grade. And they found that all of these endpoints really improved significantly. The tear breakup time, the amount of plugging of the glands also improved, and then the eyelid vascularity improved. And so these are really convincing studies when we're kind of presenting IPL to these patients. The lid vascularity improves significantly, and again, drawing that correlation between how many patients have lid vascularity and Meibomian gland dysfunction really is an important thing to draw out. The quality of the tear film itself improved significantly, which of course means that the Meibomian glands are healthier. And so this is the ARITA scale. This is a very beautiful way to describe the tear film, where you go from kind of having this pearl-like appearance of the healthy tear film to a Jupiter, and then, ooh, this really nasty crystalline-looking tear film. And so this beautiful description of the tear film actually improved at week 32 after they did this combination of IPL and Meibomian gland expression. And so, again, we know that severe Meibomian gland dropout is going to lead to these symptoms. But the thing that really caught my eye also in the study is that the speed score improved. To me, these patients were not severely symptomatic. And so sometimes that improvement in a group of patients that's not severely symptomatic in the beginning of the study is a relevant endpoint for me. Yes?
What's the reference on this study, Ahmad? Do you know that offhand?
Yes, I'll get it to you. I have it, yeah. Yeah. Mm-hmm. Scott, did you have a question? Same.
We're after the same thing.
Yeah, I have it printed out over there too. So, so this talk is not so much about just so this is really looking at the inflammation, the link between Meibomian gland dysfunction, and what else should we be doing with IPL. I typically will ask patients to plan for about 3 to 5 treatments. of IPL, but I also incorporate meibomian gland probing and then expression, because if there's an obstruction, we kind of talked about this yesterday, but if there's an obstruction, we need to understand where it is before we start putting pressure on a system that's already pressurized. And so if we're doing meibomian gland probing and it just sort of sinks in there, then that's probably maybe some sequestered meibum. But if we're doing meibomian gland probing and there's a pop, 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 then there's some fibrovascular adhesion there. And that has to be addressed before we start pressurizing a meibomian gland. And so that would be my sort of recommendation into looking at, not just kind of, and we know that IPL is an excellent treatment for lid vascularity, but how else can we be maximizing this, and what else should we be combining with it? And then how frequently should we be doing it? In my experience, it's about 3 to 5 treatments initially. And then after that, about 6 to 9 months after that, most patients would benefit from doing another round of IPL or some of the other thermal pulsation treatments, as long as we know that there's not a significant meibomian gland obstruction component. So these are the things that the talk was about, kind of what other things we can be offering. And again, I just didn't want to end the presentation without talking about eyelid debridement. And so if we're going to be offering the patient everything that we can do in the office, and we know that when we combine IPL with some of these other treatments, the end result is better, we better kind of get rid of that keratinized lid margin before we start doing probing and expression. And so I find that kind of doing this full scope of treatments and including IPL as a kind of a main treatment to treat the telangiectasia has been very helpful. And I'd invite you to kind of do the same. It's been a very helpful treatment for my patients, and I think it's really helped to clear away or improve the eyelid telangiectasia. You guys have any? I feel like I've really been talking at you this last half hour. Any questions? Yeah.
How long are you spending with the patient doing the treatment? Like if you're sort of in your mind trying to set up a schedule.
Right, right.
How have you done that? How have you implemented it into didn't have it in there already?
It's a lot more now than it was when I first started to do it, mainly because of this numbing of the lid that I think benefits most people. When I first started to, sort of do the numbing of the lid, it wasn't clear to me that everybody liked it. But then after I did enough patients with it, most patients came back with the feedback that this really helped. So if I have the real estate to have 2 different rooms, it works well. You have one patient kind of being numbed up in one room and then doing a treatment in the other room. But I'm usually, the treatment itself takes, maybe about 5 to 7 minutes or so. But the kind of the prep, just have to have everything laid out, but the treatment itself doesn't take very long, and the device basically powers up pretty quickly, so you can really burn through. You can really go through. I shouldn't have said burn. You can really go through the treatments pretty quickly, especially when they're repeat patients that are pretty comfortable.
Yeah. And are you probing? Like you mentioned that this is combined. You're either maybe combining expression or probing, whatever's appropriate. And are you doing this all the while? I mean, if they're coming in for IPL, you think, okay, I'm probably going to probe as well.
Right. So I usually do IPL, meibomian gland probing, and meibomian gland expression. But I've been doing, so I usually do meibomian gland probing on the first visit, but I don't do it on every subsequent visit. And so the meibomian gland probing part, I usually don't do as much. And so probably once, the first treatment and then the 4th or 5th treatment, do another round of meibomian gland probing, but I'd probably skip a couple of treatments in there. So do IPL, the second treatment would be IPL, meibomian gland expression. But I usually do some kind of a debridement on every visit. So it can take, I think that's the toughest part of it. It's a very smart question. You have to think about your schedule. I think the key is if you have the ability to have 2 rooms and then one person kind of working with you, so you can just kind of, after you put the gel on, you do the treatment, and you say, okay, we're going to take the gel off. If somebody can take the gel off for you, and if somebody can apply the lidocaine gel for you, those things really help. Yes? Yeah. Just along the lid margin, again, not like inside like we kind of talked about yesterday for our workshop, I just put it right along the lid margin on the outside, like no farther away than this, on the upper and lower lid.
You don't go further on the skin.
No.
And
Yeah,
what percentage?
David. It's that, so it's 8% lidocaine and 20% jojoba oil.
Oh, it's that one.
Yeah, it's the same one. Yep. It's from Tyler. I don't know if he's here. O'Brien Pharmacy. Tyler Chamberlain is the, yeah, Tyler. It's a Mission. It's in Mission, Kansas. Called O'Brien Pharmacy is where I get it.
Ahmad, from
Yep.
a practical standpoint,
Yeah.
say 3 to 5 treatments.
Yeah.
What are you looking for from a symptom standpoint or a sign standpoint to say, hey, I'm thinking about treatment 4 or treatment 5 versus
Yeah.
6 to 9 month follow-up? What are some tips that you can give for making that determination if the patient's good at 3 or if we really need to do 4 and 5?
It's mostly the lid margin. So I look for even that early. I can look for changes in the vascularity of the lid margin. So I don't really use sort of the patient's symptoms because they're really fluctuating quite a bit in that first series anyway. And you know, if we're doing a lot of meibomian gland probing initially, they're maybe not had it before, a lot of expression, it takes some time for that meibum to kind of recover. And so they might be feeling a little bit worse initially and then they feel better. So their symptoms are kind of all over, but I usually look at what's happening along the lid margin if the vascularity is improved. But most patients that have, you know, level 3 telangiectatic vessels, a lot of, you know, especially like the ones that have significant recurrent hordeola, or kind of like they tell me my lids are really thick and irritated, I always plan for 5 on those patients. They're probably going to get 5 treatments because that's what all the clinical studies, and then that one did 8 treatments. And so I've never done 8 treatments on patients 3 weeks apart, but I find that about, you know, 3 to 5, mostly 5, I plan for 5 on those patients that have those symptoms. And then the key then after that is kind of maintaining the benefit of that later. So, yeah. All right. So if it's okay, so we'll head off to have some stretch and have some food and debate what the exhibitor is one last time. And then we'll come back here and we'll talk about compounded medications. So we'll be going to take like a 10-minute break, okay?